I'm going to be speaking on hip injuries and core strength. There is an outline in your booklets as well as a copy of the PowerPoint. So we're going to change this talk up a little bit, wake people up. The talk is separated into 4 parts. So I'm going to ask you for questions and answers after each part to make it a little bit more interactive. Okay, so far we spoke about general orthopedic issues. Then Dr. Viskovich obviously spoke about foot and ankle. But integral part of preventing a lot of these overuse injuries, but even some acute injuries, is improving your core strength. And who can tell me what the core is? Who knows what the core is in terms of your muscles? Well, the core is everything from your anterior, your front, your abdomen to your back, and it goes to your quadriceps and hamstrings. So that's your core. We have a lot of athletes who go on the internet or they look in fitness magazine, get six-pack abs or improve your core strength quickly, etc. But a workout for a 25-year-old shouldn't be the same workout as a 12-year-old. So what happens is we have kids that I see every day, 7th grade, 9th grade, 10th grade. They present with hip pain or back pain, and it's not from their sport. Turns out they're doing 200 to 300 push-ups or 200 to 300 sit-ups, and that's all they're doing. So there are a lot of these excessive fitness fads out there, and we need to have some science and real research behind that. So that as a backdrop, we want to always be looking at the core because that can help prevent hip injuries and ankle injuries and knee injuries. Okay. Okay, so the outline of what I'm going to be talking about, give you a little bit of introduction on the hip, what it does, some history, what do we do about asking questions of athletes when they present with hip pain. Then we're going to talk about some physical exam maneuvers. We'll talk about specific conditions that you may see in the high school and middle school. And finally, we'll talk about preventative strategies. And then I'll break. After every 15 minutes, you'll ask me questions. So the hip, it's a complex joint. It's one of 2 ball and socket joints in the body. It's responsible for posture, responsible for walking and running. So who here has a 1-year-old or 18-month-old? They walk like robots, right? They're going to fall down. So that part of that robot or lack of neuromuscular control is their lack of hip stability or lack of hip strength. They can't get that truncal control or hip control going. The same thing when you see an 80 or 90-year-old man or woman who they're very hunched over, they're kyphotic and they're weak. They're lacking that hip strength or they're lacking that core strength. So whenever we're addressing athletes, we always want to look at their gait and how they run and how their neuromuscular control works. Now, the anatomy, there's 3 things I'm going to be talking about later with specific injuries. We have your iliac crest, which is up top, and everyone can feel that on their body. That's an iliac crest, and there is a growth plate there. We heard the Seaver's disease, which is an apophysitis of the heel. We have various apophysitis or inflammation about the hip joints. And there are 3 major sites for this apophysitis of the hip, which we'll talk about in a little bit. So we have it of the iliac crest, which the iliopsoas muscle comes off of that. We also have it off of the anterior superior iliac spine, which is where the sartorius comes off of. The third apophysitis that we'll talk about later is off of the anterior inferior iliac spine. So depending where on the hip the patient has pain, it's a different muscle group. Okay. Now, no one spoke about these risk factors for injuries. There's 2 types of risk factors for an injury. There's what we call intrinsic factors, and there's what's called extrinsic factors. An intrinsic factor is what is unique to the athlete. It's what they're born with or what they're developing into. And the most the common causes of intrinsic factors leading to overuse injury are a muscle imbalance, muscle weakness, hypermobility, and muscle tightness, inflexibility, or growth. Okay. Muscle imbalance, we often see this in athletes, again, who are just doing crunches or sit-ups. So they do have these six-pack abs, but their back extensors are really weak, so they develop an imbalance. Similarly, if we just have a soccer player and they're just running all the time, and as part of their training, they're doing excessive sprints, hill running, etc., they have an imbalance of their quadriceps muscles relative to their hamstrings. So that's a setup for hip pain as well as knee pain, having this imbalance. We can have football players, we can have soccer players that they look strong, they can bench press 500 pounds, they can do 600-pound deadlifts, etc., but they lack neuromuscular control. So when they're asked to do a plank or a bridge, which I'll show you some pictures later, they can't hold that plank or bridge position for more than 15 seconds. So we're looking at this neuromuscular control and how it controls our hip strength, hip stability, and how it enables them to move in a fluid fashion. Okay. Hypermobility. This affects 10% of the population, more likely to be females. So who here, so of the 30 or so, there should be 2 or 3, who here could put their thumb to their forearm? Okay, let's stand up, show the group. Okay, so that's hypermobile. How about your elbows? Do they
hyperextend.
Okay,
Yeah.
okay. How about your knees?
Yeah.
Okay, so those are the 3 criteria for hypermobility syndrome. I didn't pay her to come here to do that. So it's thumb opposition, thumb to the forearm. It is elbow minus 5 or 10 degrees of extension, and it's knee hyperextension, or that's called genu recurvatum. Okay, so those are 3 criteria. So she's born that way, and that makes her more likely to have musculoskeletal pain and lead to injuries because there's more range of motion. So we have to be careful with a running sport. If she's training every day, she's more likely to run into hip and knee problems because of this excess laxity. The intrinsic factors, the majority of overuse injuries that occur in children and adolescents are in this growth spurt phase, ages 12 to 15. And that's when Dr. Mann said this, and Dr. Viskovich said this, that when the children are growing, their long bones are growing very quickly, but the soft tissues, the muscles and the tendons lag behind in their growth, and they get pulled, and they get pain around growth plates. So when you hear a rip, tear, or a pop in a 14 to 16-year-old, we're concerned, that's a concerning factor, but we're always concerned about bone fractures. But when we're talking about the hip, we're concerned of avulsion fractures, and we'll get to that in a little bit. Okay. Extrinsic factors, this is the single most preventable cause of an injury, of an overuse injury in children and adolescents, where they have a training error. So we have 8th or 9th graders, they've never done cross country before, and they start running 20 to 30 miles on week 1. And after 3 or 4 days, they end up getting injured because they're deconditioned, they don't have that training mileage in there. So that's called a training error. So one tidbit, one take-home message is, this is for anyone starting a new exercise program, you shouldn't increase your training by more than 10% a week. So if you have a base of 10 miles per week, you're going to add just 1 mile a week. So it's problematic for that 9th grader who's never run cross-country before, and they start running 20 to 30 miles. Ideally, for a running sport or for soccer or something like that, you want to be running 4 to 6 weeks prior to the season, 3 times a week. So when they start running 5 or 6 times per week, they'll have some base, and their muscles and tendons will be in shape to accommodate for that. Okay, the biomechanics, how someone runs or kicks a ball, is important, because that if you have an abnormal gait, like we said, like an infant or an elderly person, and they're trying to run over and over again the same motion, and it's biomechanically incorrect, they're going to run into friction, pain, and problems. So we have to look how athletes, children, adolescents, how they walk, how they run, how they move from point A to point B. So when we're talking about the hip injury, or any injury for that matter, we always want to know, is it an acute pain or is it chronic pain? Now, a lot of the injuries that we'll see of the hip in children and adolescents, they've had chronic low-level pain, and they've been playing through that, and then they sprint or kick a ball and they feel a pop. So it's both a chronic overuse injury, but then they have an acute event on top of that. So a lot of times they're having this low-level pain, and they will see the pediatrician, or they'll go to urgent care center, which is now, they're cropping up all over the place. So they'll say, well, you're diagnosed with a hip sprain, yes, but no one asked about their training, that they're playing in 3 soccer leagues at the same time, or they're playing on 3 basketball leagues at the same time. So they'll tell them, well, rest for a week, and then there's no guidance what to do after that. And they're not talking about what are they doing for their hip core strengthening. Are they doing just crunches, again 200-300 crunches a day, or are they really doing appropriate stuff such as the bridges and the planks, which we'll talk about later. Now, there are a lot of entities that can present with hip pain. We can have patients whose origin has abdominal pain, and it can present in the hip. We can have patients who have knee pain that's coming from the hip. So you really have to be a good historian. And I do diagnose one case a year, kids who have hip or low back pain. They've had it on and off for a year, 2 years, and they turn out that they have Crohn's or ulcerative colitis. About 10% of kids who have Crohn's or ulcerative colitis will present with hip and low back pain. So we have to be thorough in this history, asking, is it really just pain for one day or a week, or has it really been going on for 6 months, for a year? And you really can't go into that kind of depth in an urgent care center where, oh, my hip hurts. You know, it's just a sprain, you know, take a week off and then go back into your activity. Okay. It's also important to know their initial injury. Were they able to continue to play? Were they limping? Were they on crutches? Because patients will not necessarily volunteer that, because they want to play, whether they're 10 years old or 18, they want to play in that tournament or that game the next day. So oftentimes they want to withhold the information. Okay. Any questions on that history part of the hip exam or definition of the core? Okay. So we'll move on. Background, Dr. Mann actually, I didn't hear, I'll have to hear it on the videotape, where he quoted that football injuries are #1 of all sports, which is totally true. And he had soccer, I think 5th or 6th, but a bunch of studies do show that soccer injuries are 2 or 3, so I'll be curious to find out about that. But there's about 15 million U.S. children, 7th to 8th grade, who do school sports. We don't organize sports. We don't have a number on who's doing trampoline, doing trampoline and skateboarding. We have emergency room visits for those type of things, but we don't have the number. But those extreme sports or individual activities, we don't truly have a number for that. But the injury rate is 10 to 50%. And how do you define an injury? An injury in the medical literature is defined as an event that happens, they're having pain, and they miss a game or practice. So someone who has a bone bruise, who never sees a doctor, doesn't miss a game or practice, that's not considered an injury in epidemiological data. So this 10 to 50%, that's why it's all over the map. Okay. Now, many of the injuries, the hip problems that I see, they go untreated. They've been having groin or hip pain. And again, the hip, truly the hip, is really groin. pain. Patients will have a groin pull, and in the medical literature, we're often calling it EIP, which is not in the slides, exercise-induced pubalgia. They have pain in the groin, in the hip when they run. And this is, again, a large differential diagnosis. Is it musculoskeletal? Is it a precursor for Crohn's or ulcerative colitis? Is it, which I have 2 case studies later, is it referred from appendicitis? Is it in women, is it a twisted ovarian cyst or a young lady? So there's a lot of complexities that can present with the hip pain. Okay, so when we do our physical exam of any joint, of any body part, we first do range of motion. And there's 2 types of range of motion. There's passive, where the examiner, the athletic trainer, the physician, physical therapist does the motion. That's passive. Shouldn't be pain with that. Both sides should be equal. And then there's active range of motion, where the patient, where the athlete does hip flexion, hip abduction, hip adduction themselves. So we want to look at active as well as passive range of motion. Okay. Now, hamstring range of motion for athletes, our goal is 90 degrees, okay? So that is 0 all the way up to 90. Now, a goal for a figure skater or a dancer, they need to be about 120 degrees. So you have to know the population that you're looking at. Now, when we have our football players, lacrosse players, soccer players, seeing a lot more in the past year, they're doing deadlifts and they're doing clean and jerks, Olympic style lifting. If they don't have 90 degrees of hamstring flexibility, they're more likely to get hip pain and low back pain. So that part of their training should be to get this flexibility going. Now, they don't necessarily need to go to yoga or Pilates or have personal training, but we really want that straight leg raising or hamstring flexibility to 90 degrees. If they don't have that, they're at risk for injury. That's number 1. But 2, when they're growing, when they're having that peak growth spurt from ages 14 to 16, their hamstring flexibility is going to go down. So that's a point where we're going to try to incorporate flexibility training in a more regimented fashion. So when I asked Dr. Biskovich, well, how much stretching should the kids be doing? In the next talk about appropriate warm-up, but stretching should be done after aerobic warm-up. If you stretch a cold muscle, you're not going to get optimal stretching. And the rule of thumb these days is to do dynamic stretching, doing walking lunges, things of that nature. Okay. Hip flexion, the goal is 120 degrees, and again, genetically, we saw our one young lady, I think she left, who had the, no, she's there, the thumb, the hypermobility syndrome, but another 10% of the population are very tight. They're born with tight muscles. So then when they go through their growth spurt, they're going to become even tighter. So a goal for an athlete, hip flexion should be 120 degrees. Some are 90 degrees, so they're going to be at risk for developing hip problems or knee problems. Okay, muscle strength testing. Basically, hip abduction. Abduction refers to going out of the body, adduction going in, and hip flexion is moving up, and hip extension is back. So those are the key ranges of motion of the hip, which you want to be equally strong on both sides. Okay, so functional tests, which we use as a screen for athletes who are potentially could get injured, and this has been in the literature since actually 1992. It's a knee injury prevention program, which we're now using it for hip or any lower extremity injury. It's a functional test. It's a 1 and 2 leg squat or 1 and 2 leg squat jump. So when you do a squat, your knees should be not below your toes. But more important than that, when you do a squat test, and one of the reasons females have 5 times more ACL injuries, and we're seeing more hip injuries now in females, is that when they land, they jump up, and then their knees cave in. Okay, that has to do with hip and core weakness. So it's these landing mechanics that could lead to hip and knee problems because their hips are weak, so it's not supporting their hips and knees in a single linear plane, the anterior to posterior direction. So these are good screening tests as well as training tests to do this 1 and 2 leg squats and 1 and 2 leg squat jumps. So, but those should be done in someone who's never done soccer and someone who's never done cross country. You don't want to do squat jumps 7 days a week. You want to start them at once or twice a week. Make sure the technique is correct and biomechanically sound. Okay, so that was the history and the physical. Questions on that, because then we have 4 cases to go over. Okay. So the first case scenario is who I see probably 1 patient a week like this. A 14-year-old soccer player. He had groin pain or hip pain, exercise-induced pubalgia pain for more than 6 months. He's able to play through that, really not limping. He then kicked the ball and felt a pop. Okay, so a pop, we said, in a growing child. In an adult, it's more likely to be a ligament, tendon, muscle. In a growing adolescent, it's more likely to be a bone problem. Okay, so in this case, we're going to be talking about hip avulsion fractures or hip avulsions. And a hip avulsion or an avulsion refers to a muscle, tendon, and a bone injury. It's not just the bone. It's the muscle and tendon where it inserts onto the bone. It pulls a piece of bone off and becomes an avulsion fracture. But this child who had 6 months of hip groin pain, for 6 months didn't have an avulsion fracture. He had an avulsion injury. It's a precursor. So it's a chronic injury overuse that's been going on, and then he kicked the ball or sprinted and then developed a fracture. So we want to catch them early on, a week, a month, 2 months into their injury, not 6 months into the injury. So this is a spectrum. Okay. This is a schematic that the abdominal muscles insert high up there, iliac crest, sartorius muscle, that's called ASIS, or anterior superior iliac spine, and then the not labeled there is the anterior inferior, rectus femoris goes into the anterior inferior iliac spine. These are common sites for avulsion fractures in growing children and adolescents, and we're going to talk about those. Okay. So, an iliac crest avulsion fracture, again, this could be the soccer player who kicked the ball. It could be the baseball player who ran to first base and they felt a pop. This is the iliac crest, and this is a growth plate. It's an apophysis, and that is widened there. Okay. Now, all of these avulsion, I'm not going to say all, I've only had 1 in 20 years that required surgery. The muscle tendon pulls on the bone, and eventually it will reattach itself, unless it's so far broken off which it needs to be surgically excised. So on this iliac crest, on the top, the iliopsoas muscle inserts. It flexes the hip and rotates the hip. Now, all 3 avulsion fractures that I'm going over, those are all hip flexors, the iliopsoas, the sartorius, as well as the rectus femoris. This iliopsoas also sometimes presents with what we call snapping hip syndrome. When we have a ballet dancer, this is classic, they do hip flexion and external rotation, and they get a snapping hip. It doesn't mean they can't continue, but it usually means that they have weak core muscles, weak in their hip adductors and abductors. Another athlete, again, they present with this pop, and then they can have a pop or an avulsion fracture off their anterior superior iliac spine. So that's this crescent-shaped moon there. And it's important that we get the pelvis x-ray as well as the right and left hip, because sometimes they can both be widened, and then it can be confusing. Sometimes the x-ray is normal, they did feel a pop, but clinically it's still called an avulsion fracture because they can't lift their leg and they can't walk. So we're looking for that pop. Hopefully we're not going to hear it in their history, and we're going to catch them earlier. But the sartorius muscle actually is the largest muscle in the body, that it spans from the hip all the way to the knee, crosses the knee. And it flexes and adducts and rotates the hip. Okay. The third type, common type of avulsion fracture is lower down, lower in the groin. And it's the rectus femoris, which is part of your quad muscle. That extends and raises the knee and flexes the knee. So many of you, it's not so important to know which muscle it is, but it's important to know that exercise-induced pubalgia or pain in the groin, we have to investigate that to make sure they don't have an avulsion injury that's turning into an avulsion fracture. Okay, so treatment of avulsion fracture. They do crutches for 2 days to a week. But right away, they actually, unless it's totally avulsed off, right away they're doing passive and active range of motion, gentle. They should be working with the athletic trainer, working with the physical therapist to get that range of motion quickly. If they don't get that range of motion quickly, they will develop contractures and have problems there. Okay. Right away, whether it's day 1 or 5 days into it, you want to do low impact movement, biking. And then once they have pain-free range of motion, they're going to be doing leg lifts, bridges, and planks. So there's a progression. Get their range of motion going, do their aerobic activity, and then do strengthening, and then eventually get back to their sport. And to safely get back to their sport, they should have full range of motion, 90% strength. Okay. That's what we just said. Return to play after the avulsion fracture should have full range of motion and 90% strength. Now, after these avulsion fractures, from when they fractured, it could be 4 to 8 weeks in severe cases. If they've had the hip pain, groin pain for a year, it may take 3 or 4 months to get back into that sprinting type of activity. Okay. Case scenario 2. And this actually just saw him 2 weeks ago, and we don't want to miss this. I will see one case a year. 10-year-old football player, he's actually flag football, but had 3 players fall on him in his flag football, okay? And he was in severe pain. He complained of hip and thigh pain. He went to the emergency department, did x-rays, they were normal. Emergency physician said he had a bone bruise, contusion. Yes, that's accurate. Follow up with pediatrician ortho if still has pain. Okay, that was the follow-up. 2 weeks, and he didn't see anyone. He was, quote, okay. And he tried going back to football. 2 weeks later, he cannot walk, because 2 weeks later, cannot walk or flex his knee. So he developed a not so rare condition called myositis ossificans. That's calcium deposit in the muscle. The most common muscle affected is the quadriceps muscle. So what happens is, yes, he had a muscle tendon bone contusion, a bruise, but the largest muscle in the body is your quad muscle, sartorius, that whole upper leg muscle. And the body, the brain, when there's a severe trauma to it, thinks it's a fracture, even though it's a soft tissue injury, and it puts down calcium in the muscle. So this is not his slide, but 2 weeks later, he had calcium deposits in the muscle, and he could barely flex the leg. Now that's going to take 2 to 4 months because it was mismanaged initially. So any child that you see in your school who has a bad thigh contusion or hip contusion, they should do range of motion exercises right away. So 2 weeks later, they're not severely debilitated with a calcium deposit in there. Okay. So a treatment of a quad contusion. This is right away. The trainers know this, therapists know this. They see them on the football field or the soccer field. They get kicked in the thigh or get kneed in the thigh. They need flexion in 12 to 24 hours, so it doesn't get a contracture, so they don't get these calcium deposits. Again, we saw this when not treated properly, 1 to 2 weeks later, it can turn into calcium deposits, myositis ossificans. Okay. The treatment, once they have the calcium deposit, indocin or indomethacin, it's one of the oldest non-steroidal anti-inflammatories, and it's used for this. It helps dissolve the calcium or helps it remodel. We do ice. We try to do low impact activity. They need to be doing daily stretching and movement exercises, not running or jumping, but doing movement, passive and active range of motion. Okay. Case scenario 3. It's a runner who presents with, it's a runner who presents with lateral hip pain. So this is a common entity, not in 10, 12-year-olds, but in 15 to 50-year-olds who are runners. They have pain on the lateral aspect of the hip, and they've been doing more hill running and increased mileage recently. Okay, so that diagnosis is IT band tendonitis. So it's truly not the hip, but we give it in the hip talk because it borders on the hip. They have pain on the lateral aspect of the hip or distal aspect of the lateral knee. And the IT band origin is that anterior superior iliac spine. It inserts onto the lateral condyle of the tibia. And this IT band, or tensor fascia lata, it's one of the few structures in the body. It's not really a muscle, it's not a tendon, it's a band of tissue. Okay? And this IT band is responsible in hip flexion, okay, adduction, and internal rotation. Okay. How do we treat the IT band tendonitis? We want to decrease that hill running. Again, when we say in life, well, just take rest, that came up on a couple other talks, it's relative rest. If you tell a patient to rest for a week, no sports, unless there's a fracture. If you tell them to rest, they're not going to rest for a week. Maybe they'll rest for 2 days. They'll want to go back in quickly. A much more reasonable and appropriate method of employment is to decrease their impact activity, decrease their mileage by 30 to 50%. Gradually do that. They're more likely to be compliant. They will feel better. Okay? So we decrease their hill running. We decrease their distance. We do the core strengthening, not 200 push-ups or sit-ups, but planks and bridges and other things of that nature. We do IT band stretching. Foam roller can help. Kinesio taping can help. Massage can help. But really, the biggest part of the treatment and prevention of the IT band is modifying their training, improving their core strength, getting that range of motion pre-season before they're injured. Okay. Case scenario number 4. A 16-year-old female tennis player has had burning pain and throbbing pain in her groin for a month. Okay. And she had intense spasms. She visited the emergency department. Now, I have this case because then she was scheduled on the day she saw me for the next day for exploratory laparoscopy, because in the ER they did a pelvic ultrasound and they thought maybe she had a twisted ovarian cyst. She's now 26, so I saw her 10 years later. She actually ended up to play college tennis at Cornell. But no one asked her in the ER or in the physician's office what was she doing. She was serving 300-400 tennis balls in a row for a week. And that, she was having low-level pain there, which she could deal with, but then she wanted to get 10 miles per hour on her serve, so she was serving hundreds of times and coming down, and she was having severe groin pain. So you got to get that history. Not just, well, what happened today? What happened a month ago? What happened 6 months ago? Okay, so her condition is osteitis pubis. Okay, so athletes get this who change direction, who do a lot of jumping, but women who have a large baby on their birth canal, they have an inflamed symphysis pubis. They have the same thing, osteitis pubis. But with the pregnant women upon the birth canal, that's a trauma, the baby's head coming out. in athletes, it's not a trauma, it's the repetitive pounding, changing of direction that inflames the cartilage in here. So normally, this symphysis pubis should be nice and smooth, but on an x-ray you'll see it moth-eaten like a mouse bit part of the bone. Okay. And a plain X, that will show up just on a plain x-ray. But sometimes in medicine people forgot the basics. So I'm having patients come in 6 months of the pain. They're not scheduled for exploratory laparoscopy, etc. That was an extreme case. But they've had 3 MRIs of that hip and groin. Well, maybe it's a labral tear, it's some tenosynovitis. They have this osteitis pubis. Right? Inflamed cartilage of the symphysis pubis, common in athletes who are overtraining, doing change of direction and kicking activities. Okay. What's the treatment? Well, if it's a year, 2 years later, it's kind of hard, but we do ice 3-4 times per day. I'm a big fan, if they're an athlete, if they have a lower extremity injury, to do the low impact stuff, the biking. They need to decrease by 50% their impact activity. They should have full strength, but their strength, but normally we want to return them to a sport pain-free. A lot of these athletes who have this osteitis pubis, they've had it a year, 2 years, they're not going to be pain-free. But we want to manage that pain so it is minimal. Okay, so we're on to the prevention aspect of this, that going into a sports season, if they're doing soccer or cross country for the first time, you'll want them 4 to 6 weeks prior to that season doing 3 times per week aerobic interval training. So doing some sprints and some 15 to 20 minute light jogs or biking, etc. The core stability things are the planks, are the bridges, walking lunges, and squat jumps. Now, the squat jumps, as we mentioned before, you don't want to be doing those daily because that could lead to problems, but we want to make sure biomechanically they are sound and that they're doing them appropriately. But a squat jump and a squat performed appropriately with the right mechanics can prevent a lot of these hip and knee injuries. So a plank, someone who's never done them, start out at doing 30 seconds, maybe 2 to 3 times per week, and they can progress it to 2 minutes. But I have recently in the past year, 2 years, a lot of patients, 15 to 50, not too many 50-year-olds, 15 to 40, who are doing CrossFit, who they're doing planks for like 4 or 5 minutes, they're doing 2 or 3 of them a row, they're doing 200 squat jumps in a session, and they're okay for a week, but their second week, they're spent, they're done. So this training rule, overtraining, don't increase the training by more than 10% per week. Okay, so EMG studies 4 years ago showed that it says the side plank, this exercise recruits the most muscle groups. It recruits abdominal muscles, it recruits lower back, hip, etc. So this is a low impact exercise that improves the core strength by the most of any exercise done by EMG studies. And we can hold that again 15 seconds, 30 seconds, a minute, etc. But to make it harder, you can lift the upper leg up and down, or you can do a scissors kick with that. So you're having a stable base, and then you're doing some movement with that as well. Okay, and these are bridges, which again, you're strengthening your core muscles. This bridge is easier to do than a side plank, so we start that first. And you can do a bridge with your leg up to 45 degrees. You can always add ankle weights to the ankle, or you can have them on an uneven board or a stability ball to make that more challenging as well. Okay. So in summary, it's important to listen to the patient's symptoms. A pop or a click is important, but what preceded that, what was going on 3 months, 6 months before that led to this avulsion fracture? And we know that prevention strategies work, but they have to be employed correctly. Again, the squat jumps should not be done daily, 2 times a week would be good. For athletes who are doing deadlifts or a lot of squatting, they should have 90 degrees of hamstring flexibility, and they should have 110, 120 degrees of hip flexor flexibility. That will prevent injury. And they shouldn't be returning to competition until there's full range of motion and ideally 90% strength. And ideally, they should be returning, except for rare cases, they should be returning to sport pain-free, and they shouldn't be masking the pain, taking Advil, Motrin, or anti-inflammatories. Okay, we'll take some questions now.
With the increase in like CrossFit and Olympic lifting in youth, are you seeing an increase in like sports hernias?
Okay. The question was, are we seeing increased sports hernia? I didn't mention the term sports hernia, which comes under the rubric of exercise-induced pubalgia. It's pain in the groin. It's not an avulsion fracture. There may be some microscopic tearing of the muscle. So the answer, we do see more of that. But we do see a lot more back pain, hip pains in general, just the CrossFit, because it makes them fit, but then they get injured because they're doing too much of that.
What about labrum tears? I've seen many labrum tears.
Okay, excellent question. The question was labral tears. The labrum is the lining of the hip, or the next lecture would be shoulder and elbow, the lining of the cartilage in the shoulder joint. And if you do MRIs in active soccer players and active lacrosse, they may show labral tears, but that may or may not be causing their pain. And a lot of times the labrum, when they're growing, is highly vascularized, so on an MRI it looks like it's a tear, and it's not. So we typically don't do much unless there's certain clicking motions about labral tears in hips in adolescence, but that could lead 20 to 30 years later to problems.
I have often have kids that come in from recess and tell me that they heard a crack or a pop. Sometimes it's in their lower leg. You know, if it hurts, I have them sit with the ice, but then what?
Okay, when I gave these cases of the avulsion fracture, yes, they heard a pop, but then they can't walk. They can't lift their leg. So you can do, as a school nurse, can you lift your leg? Yes. Can you move it back and forth? If they can do that, it's not an avulsion fracture. And they don't, with the pop that you're talking about, that's more like what we call crepitus, or the joint moved a little bit, you're leaning funny, and your elbow cracked, and that is okay. So if you've been seeing kids a long time, it may hurt and feel funny, they come in, but they're fine. They can move their elbow, they can move their hip.
You talked about ACL prevention with the jump squats. Are there other exercises that are good for that?
Yeah, there's 5 to 10 ACL prevention. Those are the lunges, the jump squats, and the bridges and the planks. I don't have a picture on there, the contralateral hold or the hunter dog stretch where you're on all fours. But all those core stability are important, but it's the landing mechanics. It's how they land, that their knees shouldn't be turned in, or they shouldn't be landing hyperextended. Okay, any other questions on the hip and the core strength?
One of the things that you said was the goals for range of motion in the hip. You said some kids are just born, they can't get to 90 degrees or 120. Is there exercises to change that they can?
Well, you're genetically, not everyone can be a ballet dancer and do all that hip turnout, but a child or adolescent who genetically they're 45 degrees of this straight leg raising, we can improve that 10-20%. So it would be the same exercises for someone who is at 80 degrees to get them to 90. You do an aerobic warm up, and then you passively lift the leg up to 90 degrees in multiple directions, and you do that multiple times throughout the day, having an appropriate warm up before that so they can achieve that. So there's genetically predetermined how flexible, but you can always improve that. But again, in the growth spurt, that's going to go down. Okay. Okay, as I said before, well, I organized the conference. I used to organize conferences yearly for 10 years now. It's been a 5-year hiatus, and it's always hard getting people to give handouts and this and that, and we can't control travel plans. So Dr. Gott, who is our 4th speaker of the morning, he apparently is stuck in New Orleans. I don't think it's Mardi Gras, but I think he had, I think he had, there were plane issues, maybe some hurricanes or something like that. So for the 4th talk, there's an outline in your packet on throwing from Dr. Gott, and you could probably call him or email him to get that presentation, but I have a handout of mine in there, so there's no slides for this one. But this one we're talking about throwing injuries. Okay, does everyone have the handout? My handout in there. It says throwing injuries with my name up top. If not, there's some up front. Right, but there should be one. So there should be up front. All right, so while people are looking for that, I didn't give, because I organized the conference, I didn't give a brief bio of how I ended up in sports medicine for kids. So 40 years ago, I was a star Little League pitcher in the suburbs of New Jersey, and I had struck out 15 batters in a game, and I had been pitching before that, but maybe once a week, every 2 weeks, nothing excessive. But in that game, I did pitch 6 innings, first complete game. Okay, and after I didn't hear a pop in the elbow. Okay, but I did have pain after the game. I told my parents the next day that I had pain in the elbow. So again, this is 40 years ago. Before the internet, before PowerPoint, etc., before managed care, and my parents took me to the local orthopedist who spent 5 minutes with me, and he said, "You have Little League elbow, no x-rays." There were no MRIs 40 years ago, but his comment was, "You have Little League elbow, you can't ever pitch again." So the first statement of Little League elbow was accurate, okay? But you can't ever pitch again was totally inaccurate, okay? But if it wasn't for him, I probably wouldn't be here today talking about sports injuries, etc., because I knew there had to be a better way of dealing with sports injuries. Okay, so why do we think there's increased Tommy John, the ulnar collateral ligament injuries in 18, 20, and 30-year-olds? Well, it's pretty clear that we have radar guns now. So kids who are even 12, they're throwing against a radar gun, and they want to see how hard they can throw. And there's more and more travel leagues and overuse. People are looking at it backwards. You'll hear any TV commentator, well, they're limiting their pitch count to 60 or 80. Back in the day, 50 years ago, the pitchers were pitching 130 pitches. Yes, that's totally true. But they weren't pitching at age 12. They were working in the farm, or they were playing football, or they were doing other activities. So it's what they were doing, what we're doing now, what the kids are doing now at 10 or 12, that they're throwing 80 pitches now. And they're doing that twice a week. That's the problem. Not that they're 25, that they pitched 110 pitches in a game. It's this cumulative effect that they've had multiple bouts of Little League elbow. Okay, so I'm going to go over the top 3 myths that I see in throwing injuries. Okay, so rest, this is again Dr. Viskovich, and it's relative rest. Rest will cure the injury. Okay, and we're talking about elbow and shoulder injuries now. So the most common thing that I'll see, and that right now I'm probably seeing 10, 15, 12-year-olds a week who are pitchers or catchers, or pitchers and shortstop, pitchers and catchers with the elbow pain or the shoulder pain. And what happened was, and they don't just have pain, they didn't just have pain yesterday or a week ago. If you really take in the history, a year ago they had pain. And they were afraid to take themselves out of the game, or it was an important playoff game. And mind you, this is a 10 or a 12-year-old. There's no college scholarships or $1 million contracts online, but it's happening that they're forced into a game. Their dad is the coach, or who's ever the coach, and they don't want to come out of the game. So really, they've had some elbow pain when they're pitching on and off for a year. So that's the biggest myth. They saw a physician, will rest for a month and the pain will go away. Absolutely the pain will go away, but why are they getting the pain? Okay, because they're weak in their shoulder rotator cuff, or they're weak in their scapula stabilizers. That's the most common thing on exam, but they're getting injured because they're pitching too much. Okay, they're having a pitching lesson once a week, then they pitch in a game once a week, and then they play catcher as well, or they play shortstop. So if they're pitching in a game, they shouldn't be playing catcher in that same game, okay? So that Little League rules have instituted that. So that's myth number one. Rest will cure the injury. Myth number two, he, she only started having pain. Now I'm talking primarily about baseball pitchers, or baseball players, because it doesn't have to be a pitcher, but we have the overhead athlete, so we also have the female softball players. The female softball pitchers do not get typically elbow or shoulder pain. They get upper or lower back pain. So we're not talking about the female softball pitcher, but the volleyball player will get shoulder pain, not elbow pain, as well as the swimmer will get shoulder pain. But what is unique to the throwing athlete, the softball player or the baseball pitcher, is that they get elbow pain at a young age. And sometimes the elbow pain, when it's on the inside, is called Little League elbow or medial apophysitis, which is an inflammation of that growth plate. And the third myth is they're having pain, they took themselves out of the game. Oh, it's just growing pains. They will outgrow that. If they're having pain with throwing, Dr. Mann said, they should continue that activity, but it's not rest, it's relative rest, and we need to look at biomechanically, physiologically, what their strength, what their flexibility is. Okay, so moving on to, and this applies to all sports, but we're specifically talking about the throwing athlete. Appropriate warm-up. Before any sporting event, but especially if they're going to be pitching, they need to have an aerobic 10 to 15 minute warm-up. Get the blood flow through their whole body, okay? So that means jogging around the field, that means doing jumping jacks, so getting the blood flow through their body, okay? Dynamic stretches, those are walking lunges or butt kickers or high knees, those are dynamic stretches. We do that, then we can do those static stretches after we have that aerobic warm-up, dynamic stretches, etc. And those static stretches, we saw that in the hip picture slide with the leg to 90 degrees, straight leg raising, or the hip flexion to 110 degrees. So for the throwing athlete, we can do things above your head, and we can do scapular stretches like that. So static stretches, for people who don't know, you ideally should hold a static stretch for 15 to 30 seconds. In dog models, they've done stretching for more than 30 seconds, and they've done analysis of their muscle fibers. If you do it more than 30 seconds, there could be some tearing of the muscle. So ideally, it's a set of 3 for 15 to 30 seconds, these static stretches, once they've done an aerobic warm-up. Okay. All right. Now, we need, because I don't have the slides, we need a volunteer to do a shoulder range of motion. So I need someone to come up here, do a shoulder range of motion.
Fred will do it.
Okay. All right, so I won't ask him till we're done if he was a pitcher or a quarterback. Okay. So come have a seat there. All right. All right, so first, again, we do the passive range of motion. So I do shoulder flexion. Okay, so about 90 degrees. So should be 90, but for a pitcher or a quarterback volleyball, we would want a little bit more than 90. Okay, so that's fine. Okay, so maybe 85. Okay, so that is fine, and it should be pain-free. Is that pain-free? Okay. Do external rotation, range of motion. Okay, so he has excellent external rotation. So in a thrower, the external, or a tennis player or volleyball, this should be 10, 15 degrees greater than the non-throw. All right, so my guess is he has done some throwing. It's 15 degrees. You play baseball or quarterback or both. So that is normal accommodation to do that. Okay, because you need that external rotation to throw effectively. Okay. Then we have the internal rotation, okay, and that is going to be tighter, and we want to improve that. Okay, so we're barely getting it to neutral. Okay, so that's 10 or 15 degrees off. So that's the normal adaptation when you throw. You have increased external rotation and decreased internal rotation. Now come stand up for me for a sec. Now, one thing which is not, the textbook face this way, we put your right arm up the back. Okay, so you want to have the thumb about to the shoulder blade. Okay, so let's do the other side. Okay, so it is about equal, but a lot of the throwers will have their internal rotation will be just to their lower back, so they have a problem with that. Okay, good. Let's see. Come sit. Let's see if we have anything else I wanted to talk about there. So that would be their passive range of motion, then they can do it actively as well. Okay. All right, so we'll get someone else for strength, thanks. Okay, so you can see just on his mechanics that he has enhanced external rotation. We need another volunteer to do strengthening. Okay, so we'll do strengthening. Okay, so we're doing an external rotation, push out. Okay, good. Push in, good. And now abduction, hands down. Okay, push up, up. Okay, so with this abduction, that is the supraspinatus. That's often weak in these 10 or 12-year-olds. Not necessarily that they're born necessarily weak, it's just a muscle group that takes longer to strengthen. So when they're weak in that abduction, and also of their back shoulder blade muscles, their scapular retraction, they're prone to getting injured. So one of these other myths, I didn't put it in the top 3 myths, is that just rest and it'll go away. But one of the things that we look at in kids who are pitching is that they all of a sudden become wild or their arm angle goes down. And that has to do with the weakness in that abduction, but also weakness in their core musculature. Okay, good. Thanks. Okay. So, okay. Well, also on the strength flexibility, everyone focuses on the thrower, about their shoulder strength and their elbow strength, their biceps, triceps, but probably 3/4 of the preventative strategies in those kids, adolescents, and adults who throw comes from their core strength. So throwing a baseball, they're not enhancing their core strength. They got to do other things, and this why the hip or the core strength is so critical in preventing injuries. So we talked about the side planks and the side bridges. Having that core strength will protect shoulder and elbow injuries. Okay. Same thing doing this dynamic strength, those 1 and 2 leg squat jumps. If they have good stability with that, that's going to be protective of their hip and of their shoulder and elbow injuries. Okay, any questions on that before I go into specific injuries?
Did you
mother let you play after the doctor said you were pitching?
Actually, I didn't pitch for like 3-4 years. So, okay. All right. Any questions on the physical exam? Yeah.
How do you deal with kids who have hypermobility, who are pitchers or catchers, and they're doing this active and passive rate, but they can go a heck of a lot further just based on their hypermobility?
Excellent question. What do we do about the pitchers and catchers who are hypermobile? Well, they're more prone for injury. Tim Lincecum, I had never examined him, but he has extreme hypermobile joints. So they need a much more organized, proficient strengthening program. And they need to look at their pitch count at an earlier age, monitoring that. And again, they shouldn't be pitching and catching in the same day. And they need adequate rest in between their starts. Okay, excellent question. Okay, so we'll start with the elbow, since that's what we're talking about. Mostly that 90% of kids, boys and girls who throw, will have 95% will have medial elbow pain. Okay, so that's inside the elbow. And that's called medial apophysitis, and that's diagnosed on exam. But all those kids who are pitching, who are throwing, they do need an X-ray. Okay, so we're looking at the growth plate or the medial apophysis, and generally we look at that as a grade 1, grade 2, or 3 injury based on exam. This is important, and on X-ray. We'll talk about the MRI in a minute. The X-ray on a grade 1 will be normal. An X-ray on what we call a grade 2, there'll be a little bit of widening of the growth plate. And a grade 3, there'll be a fracture or the bone broke off the growth plate. So those are grade 1, 2, and 3. We want to catch them. I'm 100% convinced I had a grade 1 injury. I didn't hear a pop. It was the first time I ever had pain in the elbow. So I was, over treated, but that's why I'm here today. So those are grade 1, 2, and 3. Now, everyone wants an MRI, okay? So a 12-year-old who has a first-time elbow pain, they're not going to tear their ulnar collateral ligament. They're, as Dr. Mann said, Dr. Biskovich, and I'm repeating, the kids, especially 12, 14, when they're growing, the bones are weaker than the ligaments. So the Tommy John ligament pulls on the bone, causing a fracture, stress fracture widening. So you get an MRI of the elbow, and they'll say, and again, it depends on the radiologist interpreting. They don't have the patient there. They say maybe a partial tear of the ulnar collateral ligament, maybe a cyst, and this elevates the tension and the anxiety of the patient. Then they see another doctor. So a 12-year-old first-time little league elbow does not need an MRI. In fact, it could be counterproductive for the treatment. Okay, it's different if it's gone on a year or 2 years. So a grade 1, there's no X-ray change. A grade 2, it's widened. Grade 3, it's fractured. Okay. Now, I said 90 to 95% of the elbow injuries in throwers are medial. Okay. 5 to 10% are lateral. Okay, outside. Okay. Now, they need an X-ray, but they need an MRI with the thrower. Why is that? Because they can have what's called OCD, or osteochondritis dissecans. That's a lack of blood flow, like the Kohler's disease or the Freiberg's disease of the foot. They can have a lack of blood flow to the bone. It could be dead. Okay, that needs an MRI because that won't show up on the X-ray. So it's not get an MRI in everyone when they have lateral elbow pain. We're ruling out osteochondritis dissecans. So what if we miss? They present 3 years later, and I just had a young man who is now finished his freshman year of college, and he had the OCD of the elbow, osteochondritis dissecans, at age 12, and it was a 1-inch crater in the bone, which barely showed up on an X-ray. But he had been pitching from 9 to 12, like 3 seasons out of the year. and he was, quote, this star pitcher, and he ended up, he didn't even play baseball in high school because he threw out his arm at 9 or 10. He didn't tear his Tommy John ligament, but he threw too much at a young age. So people probably have not heard of the osteochondritis dissecans, OCD, but you've heard of the microfracture surgery. That's what this is. These are microfractures. It's a hole in the bone. It degrades the bone as well as the cartilage, and if that goes untreated, it leads to bone chips there. And you want to catch that at 11 or 12, that this lateral elbow pain, because if they have a 2 millimeter crater in the bone, that's going to heal. But if they have a 2-inch crater, that's not going to heal. And then do you do surgery on that? Do you do not? That becomes very complicated. Okay, so we didn't go over simple preventative exercise for the elbow, but we went over the stretching, the hamstrings, but preventative isometric exercise for the elbow, both for the medial elbow pain and lateral elbow pain, are the simple isometric stretches like that you've seen for, quote, tennis elbow. 15, again, to 30 seconds, 15 to 30 seconds throughout the day, but ideally after aerobic activity. Okay, so that's isometric stretches for the elbow. And in addition, we want to do strengthening of the forearm muscles. So having therapy putty or stress balls, and we've had people over the years talk about having lima beans or coins you grab from one Tupperware to another, just grabbing that, strengthening the forearm muscles. Also, wrist curls are good at strengthening that. But those are directly for the elbow. But again, strengthening the rotator cuff is protective of the elbow. And again, in those young pitchers, or even the female softball players, they're weak in this abduction and the scapular retraction. So we want to strengthen that as well as a preventative thing. And those could be, again, 3 times a week, the strengthening, but the stretching throughout the day, especially during the growth spurt. Okay. So it is rare to have an ulnar collateral ligament, a Tommy John ligament tear, under 14. But the precursor for that is really the Little League elbow for that they're having too much stress to that area. So if they keep doing that, then the bones fuse. Now they're getting into a ligament injury. Whereas before the growth, they have this bone injury. Okay, questions on the elbow?
It's more of a comment, but
Sure.
I think for the adolescent age, a lot of the kids are on their cell phones a lot too, so they're hunched over, their pecs are going to be tight, their scapular retractors are going to be weak, and I think it's like teaching them a lot of like postural
Okay,
stuff
excellent
as well.
point. The internet and the texting will lead to poor posture and weakening and tightening of the muscles. Absolutely. So that's an overuse, not from a sport, but from societal.
Right.
So that postural training and postural awareness is absolutely critical. Okay, any other questions on the elbow? Okay, so we'll move up to the shoulder. Okay, so the shoulder injuries in the throwers or the volleyball players or the softball players. Again, when they're in those growing years, the 12 to 16. Now, again, there are some boys or girls who are skeletally mature at age 12, meaning they're finished growing. Okay, so they're age 12, but their bone age is 16 or 18. Okay. There are some 16-year-olds whose bone age is 13. So it's not the chronological age necessarily, it's where they are in their maturity. So you have to take that into consideration as well. But in the growing adolescent, in the growing thrower who has shoulder pain with pitching, with throwing, it's typically not rotator cuff injury, okay, or labral tear. It's growth plate, it's the bone. And we said that the medial elbow, they call that in the literature Little League elbow. In the shoulder, in the 12 to 14, 16-year-old, it's little league shoulder. So it's an epiphysitis or it's actually not apophysitis because that's an accessory growth plate, but it's an epiphysitis, it's a growth plate inflammation of the shoulder, the proximal humerus. And if it wasn't explained before, the growth plate is a space, it's a void in the bone where there's cartilage and dead space, and that has to fuse and then get stronger. So that growth plate is vulnerable because it's vulnerable to those shearing forces. So similar to the Little League elbow where we grade it 1, 2, 3, the 1, 2, 3 for x-ray, and all of the throwers who have shoulder pain should get the x-ray, and we'll talk about that MRI in a minute. The x-ray of a grade 1 is not going to show anything. The grade 2, it'll be a little bit wide, and 3, it's a fracture, and then it could be different types of fractures, the Salter-Harris fractures, but we want to catch these shoulder injuries or growth plate injuries in the throwing athlete when they're just having it for a week or a month. And again, don't let the parent or the child convince you otherwise that this is the first time ever they ever had pain in the shoulder. Because if they're coming in to see the specialist, they've been seen by their pediatrician several times, they've been seen by urgent care several times, and that may have been 1 or 2 years ago. So you really need to look into their pitch count, per game, per week, per year, etc. How much are they pitching with the dad in the backyard, etc. Okay, so what the kids do get, and which is similar to the adults in the shoulder, they do get what we call shoulder impingement. Okay, it's not a true rotator cuff tendonitis, but when they lift their arm up and they abduct and internally rotate, they may have some looseness of their shoulder joint, of their capsule, and that impinges or touches upon the rotator cuff muscle. So that would be similar in a child as well as an adult. That's more, and it's hard to distinguish sometimes pain versus soreness, but that's more soreness rather than the pain per se. Another presenting symptom that the athlete, the throwing athlete will present who has the shoulder impingement is they sometimes feel their shoulder, and they're not loose jointed, they feel their shoulder popping or rolling in and out. So they develop, as a colleague of mine said, he's from the South, developed Cadillacs in the front and Volkswagens in the back. So they have an imbalance of the pec muscles versus the scapular stabilizer. So they're constantly rotating the shoulder forward, and they're getting popping, not as in the hip tearing popping, but they're getting this crepitus, this movement, this abnormal rotation. And again, we want to do the scapular stability exercises for that, and postural training as well as getting off the internet and the cell phone so much. Okay, now any questions on the shoulder injuries, because then we're going to go into pitch counts briefly.
How can you tell the difference between bursitis pain and
Okay.
shoulder pain?
Okay. Question was, what's the difference between bursitis pain and shoulder pain? Kids can get bursitis, but that's really a non-specific diagnosis for just inflammation in the joint. Kids who are having true pathology, they're having pain when they throw. They're not just having soreness. So the bursitis that they're just sore, and I don't think I've really given a kid a diagnosis of the shoulder of bursitis, but typically a distinguishing feature is they're sore. If you've worked out hard, your muscles are sore. It feels like that. Whereas in pathology pain, they actually have pain. They're changing their arm angle. They're changing their biomechanics, etc.
What about weakness with dislocations versus mechanical where it has to actually be fixed?
Okay. In children and adolescents, it's rare from throwing that they'll dislocate their shoulder, but the kids still sometimes play multiple sports, so they may have dislocated their shoulder in football, lacrosse, and that would take really 2 to 4 months perhaps to gain that full strength, so they have inherent weakness from just that their shoulder dislocated. So that's an important historical piece. Did they dislocate or partially dislocate their shoulder? They're not genetically weak, but they had an injury, a traumatic event, maybe snowboarding or what have you. Okay, pitch counts. There are various pitch counts that are available through Little League Baseball and USA Baseball, and they're good that they're in place, but they're not adhered to. So for a 12-year-old, I believe the largest pitch count is 85 in a game. For 16 to 20, it's 100. Okay, so that's in a game. But again, a lot of these 12, 14, 16-year-olds, they are pitching with a pitching coach once a week, and they're doing 100 or 120 pitches in that session, and then they're doing 100 pitches in the game as well. And also, although the Little League coach or the travel coach, yes, they monitor the pitch count appropriately, but that's not taking into account they're on another team, or they're doing the pitching coach. And it's what I said before, it's not so much what they pitched in one game, it's what they pitched in a season or what they pitched in the past year. And when they go crazy, again, professionally, well, they pitched 120, but why are there more injuries now? It's not because they pitched 120, it's because they've been pitching 100 pitches in a game since they're 11 or 12. That's the issue, it's cumulative. And I make the analogy, it's like you change your car tires, the pressure, you're going for a checkup every 5,000, 10,000 miles. When the kids have excessive mileage on their shoulder or elbow, you can't reverse that. So how can we reverse that? Is that maybe they'll pitch once a week every 2 weeks. And we don't do that 100 pitch count like everyone else. Maybe they're on a 50 pitch count and they only do 15 minutes of pitching lessons once a week. It's not do everything or do nothing. We want to let them enjoy their sport or activity at the same time trying to protect them for years to come. Okay. So what would I recommend? Because I see pitchers. This is the first year actually in 16 years that I haven't coached Little League Baseball. My oldest is graduating college this Sunday. So when he was 5, I coached baseball. So it's the first year not. But so ideally on a team you have multiple pitchers, okay? But usually there's only 2 or 3 pitchers. But the best way of doing that is to have the kids pitch 2 or 3 innings, and we'll keep, like twice a week, and be on a strict rotation. But what happens is there's not someone who's sick didn't show up. There's not adequate warm-up. Again, warm-up is so critical, doing the 10 to 15 minute warm-up, doing the dynamic stretching, then throwing, and then they're ready for the game. So ideally, they should be pitching twice a week, small amounts, and then it's safe to use that 10% rule. So if they were pitching 40 pitches, at the beginning of the season, increasing their pitch count 10%, 5, 10 a week, and then they're peaking at 80 or 100 pitches in a game, not pitching 100 pitches in every game for 10 sessions. So that's physiology, biomechanics, and wrapped up in 10% a week, but you want to be peaking at that number, not because Little League Baseball, USA Baseball said they can pitch 100 pitches, and they do that for the whole season, but that's where we run into problems. Okay, we can talk about the biomechanics. There's now great computer simulations and models and television and video looking at arm angles and hip rotations, so that can optimize what's the proper pitching motion, which creates the least amount of stress on the shoulder or the elbow. But again, 70 to 80% of the prevention biomechanically comes from the lower body. If they can't do a squat jump, appropriately, they're gonna run into shoulder and elbow problems. If they're doing, again, too many pitches, too many innings, that's correctable. You gotta do less pitching which would lead to less shoulder and elbow injuries. Okay. A lot of work has looked into the hip rotation. What's the optimum hip rotation when they're pitching? So a good pitching coach, 20, 30 years ago, they didn't have computer models. They can tell you, but I will speak to pitching coaches, and we now instituted a throwing program for the kids, looking at the whole body, what we've outlined, looking at their scapular stability, looking at their hamstring flexibility, and then we'll consult with the pitching coach what their proper mechanics should be. But if we don't have the proper strength, if we don't have the proper range of motion, and they're pitching too much, they're going to run into problems. Okay, questions on the biomechanics?
What would your argument be to, some people who are now coming up, everybody's looking into why there's an increased incidence of UCL injuries. What's your argument for people saying that the biomechanics of throwing motion is too good, and that's what's causing more torque in the elbow and causing more UCL tears?
Yeah. I'm open, so the question was, with the good biomechanics, maybe that's leading to UCL injuries. It could be, but what I think is the biggest problem with leading to elbow injuries is too much at that young of an age, even with the proper mechanics. So
too much volume.
Yeah, too much volume. The other big thing, we don't see too many kids who are at the high school level who are very hypermobile. They kind of get weeded out. So they have good biomechanics, and then there's always an argument, well, is it overhand or three-quarter or sidearm? In the major leagues, I don't know what percent are sidearm, but majority are three-quarter. But one important point is that a 12-year-old, it is rare that they take themselves out of the game, but a good father or a good coach or a good mom will know how their child, son or daughter, throws. If their mechanics go down, well, now they usually have good control. Now they have bad control, or they're pitching too high, they're pitching too low, something that doesn't, and it may not be at 100 pitches. So people, I go to games all the time, they're just counting the pitches, but what's the quality of the pitches, which is important. But so it's not sure how that biomechanics is more, but I totally believe that it's just the overuse, the volume at that young age, and that they're clocked at 10th and 11th grade trying to throw too hard instead of nice and smooth.
So you bring up a good point about the arm angle, only because we rehabbed a ton of Tommy Johns, and it's interesting that when they are allowed to go back to the interval throwing program, that all of a sudden they go back to the interval throwing program, and you find that the athlete who had the UCL Tommy John surgery, now all of a sudden they have a shoulder problem, and it's only it was only because that they had the shoulder problem, and it led to the elbow problem. And now all of a sudden they're trying to go back and they have the shoulder problem that has to get fixed.
Right. Well, the other point is, and that's why I brought up the hip with the core, these things lead to one another. If they're weak in their core and their hip or their hamstring mechanics, it could lead to show up in the upper body. If they've had an elbow problem, we even go into that, they may have had a shoulder problem before and not known it, or vice versa. So it's not, you can't just look at an elbow or look at your shoulder, but unfortunately a lot of people are doing that. Got to look at the whole body and what other body parts have been bothering you, and again, pre-season, what was their external rotation, internal rotation, and what did their delivery look like now compared to a year ago. It's very complex. And it's easy just to fix. You can fix the elbow, fix the shoulder, but why did it get hurt? The volume, the mechanics through their body, the whole thing. Questions?
Now with kids with having shoulders, elbow problems, we start working on breathing mechanics. That's the first thing we check. How do you breathe? Breathe is going to affect the whole motion.
Right.
You just go on the shoulder, the elbow. We are taking apart the movement of the rib cage. The rib cage is going to affect your spine, and that's the first thing we work with them. We work on proper breathing mechanics, and then from there we keep moving to the shoulder, to the elbow.
So you're looking at thoracic spine to see if there's any indication if
the problems come from the upper extension lumbar spine, because we teach them how to breathe properly, and then we move to everything else.
That's an excellent point with the breathing. been a bunch of research, I can't remember, I think it was out of Hopkins. It wasn't breathing per se, but it's posture.
Hyperextension.
Posture as well as the muscular contraction and relaxation cycle, which has to do with the breathing.